ಕೈ ಕೊಡು ಕೈ. ಬಂದ್ರ
today I started going to Teresa first, then Mahalakshmi Layout hemodialysis unit, and then Rangadore, and then first hospital. I am going to St. Teresa Hospital dialysis unit, which is run by Rotary. Mr. Nagendra is an ex-chairman of Rotary who is running this dialysis unit very effectively. Hospital, the hemodialysis unit is run both by Teresa Hospital in collaboration with Rotary. So today we will know what is CKD-MBD. CKD-MBD is mineral bone disease which happens in chronic kidney disease patients. So it is characterized by abnormalities of calcium, phosphorus minerals, vitamin D and parathyroid hormone. It affects the bone after the stage 3 of CKD, where there will be abnormalities in the mineralization, bone turnover, volume, linear growth or strength of the bone. We have to address it early in CKD patients to prevent bone fractures as well as cardiovascular complications. Why there will be CKD-MBD in CKD patients? After the stage 3 CKD, there is a decreased excretion of phosphate from the body. See, kidney is important organ to excrete the phosphate from the body. This phosphate mineral gets accumulated in the CKD after CKD stage 5, leading to hyperphosphatemia. Second, patient will have hypocalcemia. The kidney is required for conversion of inactive vitamin D into active vitamin D, and active vitamin D causes the absorption of calcium from the gut as well as from the kidneys. And because the kidney function decreases, this the decreased vitamin D, there is a decreased absorption of calcium from the gut as well as from the kidneys. This leads to hypocalcemia. Third, because there is a hypocalcemia, there is a activation of parathyroid hormone from the parathyroid gland. So this parathyroid hormone, which is released, causes reabsorption of calcium from the bones as well as from the gut. So eventually this leads to demineralization of the bone, weakening of the bone, and these patients are prone for fractures. So eventually there is a severe demineralization of bone in the CKD patients. And hyperphosphatemia as well as calcium phosphate products sometimes cause problems, get chelated and can be deposited in the vasculatures or blood vessels, leading to cardiovascular complications. So how to manage this complex problem? So CKD-MBD, the management starts early. In the stage 3 CKD, we see all the parameters: vitamin B12, calcium, phosphorus and serum PTH. When there is a low calcium level, we add active vitamin D. Before that, we advise them to take low phosphorus diet. What are the low phosphorus diet? The dairy products has to be avoided. Red meat has to be avoided. So we advise all this so that the phosphorus levels is maintained in a range. So first thing is to maintain the phosphorus level. If it's not possible, then we add phosphate binders. There are drugs where it absorbs the phosphate in the intestine and reduce the phosphate level. Third is when there is a serum PTH is high, then there are drugs like calcium mimetics, like cinacalcet, where it reduces the serum PTH level. But we have to monitor again calcium, phosphorus, and PTH and adjust that accordingly. Fourth is strengthening the bone. So we have to give weight bearing exercise so that they strengthen the bone. Fifth is regular monitoring of calcium, phosphorus, serum PTH, vitamin D3 level, so that we correct accordingly when there is a deranged parameters. Last but not least, avoid smoking, excess alcohol. All this are important. Thank you.